Dear distinguished guests, thank you so much for joining the APGS symposium. This symposium will be run in a debate format focusing on the dilemma in glaucoma management. 8 speakers will discuss on the acute angle closure, disc hemorrhage, juvenile open-angle glaucoma, and neovascular glaucoma. You may have a view on how to manage these issues from the Asia-Pacific perspectives. Our co-chair, Dr. Prin, will moderate this symposium together. I hope you may enjoy the symposium. Thank you.
Hi, I'm Prin Rojanapongpan from Bangkok, Thailand, co-chairing with Kiho Park on this dilemma in glaucoma management. We're going to have 4 debates. The first one starts by best initial management of acute angle closure by Krimentam speaking on ALPI and paracentesis versus medication by Mimiwati Sahari from Malaysia. The second debate on disc hemorrhage in NTG. Should we do immediate intensified treatment by Professor Sugiyama from Japan or just monitoring by Paul Healy from Australia? Then the third debate will be uncontrolled IOP in JOAG. Should we do mixed by Visini Tantisevi from Thailand or just tabectomy by Lingam Vijaya from India? End up by normal by NVG. Should we do primary trap by Narustam Bangladesh versus primary tube by Suran Chang from China? I hope you enjoy the debates.
Ladies and gentlemen, I'm Clement Tam from the Chinese University of Hong Kong. In this small debate, I'll be speaking for argon laser peripheral iridoplasty and paracentesis as possibly the best initial treatment for acute primary angle closure. These are my financial disclosures. Now, first of all, let me start by presenting to you my own personal approach in managing APAC in 2021. In the first stage of treatment, when we aim to reduce intraocular pressure and to relieve symptoms, my personal preference is immediate laser peripheral iridoplasty with either argon laser or diode laser. And then in the second stage of treatment, in which we aim to reduce recurrence of the acute attack, as well as to prevent progression to the chronic form of angle closure, my personal preference is early lens extraction. Now, but for the purpose of this talk, in addition to sharing with you the pros and cons of iridoplasty, I'll also be talking about paracentesis for your reference. Now, laser peripheral iridoplasty is a laser technique that involves the application of laser contraction burns in the peripheral iris in order to open up positionally closed portions of the angle. You can see that with the laser application, there is thinning of the iris stroma at the point of laser application, and this widens the drainage angle and reopens very effectively those portions of the angle that are appositionally closed. Now, typical laser parameters, we normally go for a larger spot size. You may consider about 500 microns, and a longer duration, something like 0.5 seconds. And for brown iris, we normally start from a very low power of about 150 to 200 milliwatts. And of course, we have to titrate the power and to titrate the settings against what we see at the slit lamp. Now, this is a video of argon laser peripheral iridoplasty. You can see that when the laser spot is applied, there's contraction of the iris towards the laser application site. And this pulls open, mechanically pulls open and positionally closed drainage angle, and thereby allowing drainage of aqueous through the open angle once again. And the one very critical tips on the application of iridoplasty is that you have to apply the laser as far periphery on the iris as possible, because otherwise it will not work. Now, this is a randomized controlled trial conducted by our group in which we directly compare argon laser peripheral iridoplasty against IOP lowering drugs in cases of acute primary angle closure. And you can see that the red line represents those eyes treated by ALPI, whereas the green line represents those eyes treated by conventional IOP lowering drugs. You can see that with ALPI, there's a much more rapid reduction in intraocular pressure, which is associated with a more prompt relief of the symptoms of acute ocular hypertension. So apart from IOP control, in fact, for those eyes treated with immediate ALPI, there appears to be also a lower chance of progression to the chronic form of angle closure as compared to eyes treated with systemic medications. Now, even though ALPI is very effective in lowering IOP, it has its own limitations. For example, the laser machine or perhaps the laser expertise and experience may not be readily available around the clock everywhere. And furthermore, even with ALPI, it does take time to reduce the intraocular pressure. And so is there a potential alternative? Now, perhaps anterior chamber paracentesis could be one of these alternatives. It has the advantage of almost immediate normalization of intraocular pressure and symptomatic relief, and it may also reduce irreversible nerve and tissue damage because of the more rapid IOP reduction. It does not require any expensive equipment, and because paracentesis is performed frequently in other settings, such as during phaco emulsification, so most eye doctors are familiar and confident with this procedure. But because it is an intra-invasive procedure, it is associated with risk of infection. The sudden IOP drop may cause choroidal effusion and hemorrhage, and also there's a chance of sharp damage to cornea, iris, and lens, and also perhaps an increased risk of malignant glaucoma. And more extensive clinical trials are certainly warranted to evaluate the efficacy and safety of paracentesis. Thank you very much for your time and attention.
Good afternoon, ladies and gentlemen. My name is Niniwati Zahari, and I'm from the University of Malaya Medical Center from Kuala Lumpur, Malaysia. I would like to thank the organizers for inviting me to participate in this wonderful meeting. I hope by the end of the 5 minutes, I'm able to convince you that the best initial management of acute primary angle closure is medication. I have no financial disclosure. If you're faced with the eye, which looks like this, very angry and red, a mid-dilated pupil and a very shallow anterior chamber, you jolly well know that you are facing with a medical emergency. Angle closure glaucoma has very serious long-term consequences and is potentially blinding. In order to avoid this blindness, we must act quickly in reversing the attack and reducing the IOP. As you know, the mechanism of angle closure glaucoma is a pupillary block mechanism. In order to circumvent this, we need to do a peripheral iridotomy or peripheral iridectomy. However, this is not so easy if your cornea is still edematous and the iris is still swollen and inflamed. Therefore, we need to start treatment immediately to lower the IOP. And in the conventional way, we have always been using medical treatment. The main aim is actually to clear the corneal edema, and this will also alleviate any inflammation, pain, and nausea. So in our armamentarium, there are lots of glaucoma drugs to use, and fortunately for angle closure glaucoma, we are able to use them all. And it is actually suitable to treat the angle closure. However, since we need a rapid decrease in IOP, the intravenous acetazolamide is used. Usually we give 500 milligrams stat dose, as this will decrease the aqueous production. The efficacy is quite good. In the plasma levels, it will peak within 1 hour, and the peak IOP reduction is within 2 hours. We also give pilocarpine, and as this will constrict the pupil and increase the outflow of the aqueous. However, please note that this may not be effective at very high IOP. This is due to the pressure-induced ischemia and paralyzes the sphincter of the iris. Therefore, most of the time we need to reduce the pressure by other methods before installing the pilocarpine or before expecting the pilocarpine to work. Unfortunately, with pilocarpine, there is also a paradoxical pupillary block mechanism, and this is why some of the other cholinergics in its class are not used. The other topicals are also suitable for treatment of angle closure glaucoma, and even prostaglandin analogs, despite its mechanism, is to improve outflow of the aqueous. Hypoosmotic agents are also used if all these medical measures if all the other medical measures are enabled to reduce the IOP. So we have been using medical treatment all this while, and studies have shown that this is very, very effective, and there's very little side effects with the medical treatment. However, my esteemed colleague has probably convinced you that ALPI is also safe and very effective, but he has probably not told you the many disadvantages of ALPI, which is cost. You need sufficient skill to do the procedure. The patient may be uncooperative because they're still in pain. You have to put the lens on the eye, which is very uncomfortable. The technical difficulties abound because the cornea is still cloudy, and you may not get a good burn, and the pupil is still fixed and dilated. And it is also not effective in eyes with significant peripheral entries and decay. There's also a whole list of other potential complications of ALPI. A meta-analysis of RCTs evaluating the ALPI versus medical therapy, of course, did show that both are equally effective. And but in the long term, there is no significant difference between the two groups. Therefore, the advantages is only in the immediate few hours where ALPI is more effective than medical therapy. The other method which was mentioned is anterior chamber paracentesis. And as you know, the main problems with, other than this being technically difficult to do in a hot eye, is that there is a real risk of infection, as this is a very invasive procedure. And this will not eliminate the pupillary block even. So therefore, in summary, medical therapy versus ALPI and anterior chamber paracentesis may give us lower rates of IOP lowering, but there is no evidence that the short delay causes more damage to the optic nerve or anterior segment structures. Medical therapy is safe without the surgical and laser-related potential complications made worse by the technical difficulties faced in an acute setting. There are no long-term benefits in choosing ALPI or AC paracentesis over the traditionally well-accepted method of medical treatment. So in conclusion, given its relative safety and efficacy, the initial treatment for acute angle closure should be medication. I thank you for listening to this talk.
I'm Kazuhisa Sugiyama from Kanazawa University, Japan. I would like to talk about disc hemorrhage in NTG immediately intensified treatment at this debate session. The slide showing one case, intensified treatment or same treatment after disc hemorrhage or DH. Intensified treatment after DH case is shown in the upper. In non-DH quadrant, the rate of RNF thinning of minus 3.3 micrometer per year before DH decreased to minus 0.8 micrometer per year after DH. In DH quadrant, the rate of RNF thinning of minus 4 micrometer per year before DH decreased to minus 2.9 micrometer per year after DH. The glaucoma medication was intensified from 1 to 2 eye drops after DH. The speed of RNF thinning decreased in both DH and non-DH quadrants by intensified treatment after DH. On the other hand, the same treatment after DH case is shown in the lower. In DH quadrant, the rate of RNF thinning of minus 0.5 micrometer per year increased to minus 5 micrometer per year after DH. In non-DH quadrant, the rate of RNF thinning of minus 0.2 micrometer per year before DH increased to minus 1.1 micrometer per year after DH. The glaucoma medication score was 2, which was not changed after DH. The speed of RNFL thinning increased in both DH and non-DH quadrant by the same treatment after DH. Slide showing intensified treatment improved RNF slope value after DH in both DH and non-DH quadrants. Positive value indicates that the rate of RNF thinning became slower after DH. Negative value indicates that the rate of RNF thinning became faster after DH. The dark box plots indicating that in global DH and non-DH quadrants, the rate of RNF slope value significantly slowed in eye with intensified glaucoma treatment. The slope became significantly faster, more negative in the DH quadrant in eye without treatment change. Slide showing the cumulative incidence of DH in ocular hypertensive patients. The hazard ratio for developing a disc hemorrhage in the medication group was 0.7, so DH occurred 30% less frequently in medication group than in observation group. The slide showing the cumulative incidence of DH before and after trabeculectomy in POAG and MTG. IOP reduction by trabeculectomy significantly decreased the frequency of DH in both NTG and POAG. In summary, intensifying treatment can slow the rate of RNFL thinning in eye with DH. Although the rate of RNF thinning worsens in a DH quadrant after DH, glaucoma treatment intensification may have a beneficial effect in reducing this rate of thinning. IOP lowering medications or trabeculectomy can reduce DH frequencies. Thank you so much.
Thank you very much. We've just heard a wonderful talk from Professor Sugiyama about why we should accelerate treatment immediately when we see an optic disc hemorrhage in normal tension glaucoma. I'm going to present the other side of the coin, the case for monitoring. I have no commercial affiliations or conflicts of interest for this content, but please remember, this is a debate, and the sides of monitoring versus treatment have been ones chosen by the organisers rather than chosen by the speakers. So I'm not going to argue that optic disc hemorrhages are not important. They are. They're very important, as you've heard. In the OATS trial, Bedenz reported that 10% of the cohort developed a hemorrhage, and over 13 years, there was a 2.6-fold increase in the risk of development of open-angle glaucoma in those who had disc hemorrhages. Bengtson in the MGT study reported that the 8-year prevalence of disc hemorrhage was some 55%, the majority of patients in the study, and that those with disc hemorrhages progressed faster with a hazard ratio a little over 1. There have been a number of excellent systematic reviews and meta-analyses, and I'd recommend those by Drs. Kim and Park from Korea and Professor Yamamoto from Japan. And they have documented many studies where disc hemorrhage has been associated with faster progression. But may I point out, often those studies have shown progression that has been faster prior as well as after the disc hemorrhage event. So why not accelerate treatment? Well, if we go back to the MGT, that population-based randomized controlled trial found no evidence for a treatment effect in terms of disc hemorrhage and progression, to the extent where the authors actually suggested that their results suggested that disc hemorrhages cannot be considered an indication of insufficient intraocular pressure lowering. And it's a little hard to go past one of the most important studies in glaucoma for the evidence of whether or not we need to accelerate treatment. But what about the other studies? Well, if we look through those systematic reviews, we do find one study that suggested a reduction in progression rate after disc hemorrhage and pressure lowering. And this was a paper by Felipe Medeiros in Ophthalmology in 2010, and it's an excellent paper. But there's a few things to consider, particularly in the context of this talk. Firstly, the baseline pressures in the cohort of patients was almost 25 millimeters of mercury, hardly normal tension. Secondly, prior to disc hemorrhages, the intraocular pressures were 20, which is still too high. And after the disc hemorrhage event occurred, the clinicians intervene by increasing treatment and bringing the pressure down to 14. So in other words, after the disc hemorrhages, the pressures were lowered by a greater amount than they were at initial diagnosis and treatment. And to achieve that, almost a third of those patients needed a trabeculectomy. So what's the case for monitoring? Well, disc hemorrhages are common. We know that, particularly in normal tension glaucoma. If we accelerate treatment on everyone with a disc hemorrhage, we'd be doing an awful lot of trabeculectomies on those patients. Some patients who progress faster develop disc hemorrhages. Now, I know this sounds like the opposite of what I said before. Don't disc hemorrhages cause the progression? Well, if one looks at this very nice Survey of Ophthalmology article, which has just come out by Dr. Lee, the evidence for disc hemorrhages as being a risk factor for glaucoma is actually very poor. And what they really are a sign or an indicator of ongoing damage. So in other words, disc hemorrhage does not cause progression, but progressing patients do sometimes develop disc hemorrhages. And patients with disc hemorrhages sometimes show progression later on. What causes progression? Well, we know what causes progression. It's intraocular pressure. So here's an approach to normal tension glaucoma and disc hemorrhage. If the pressure is too high, then lower it. That's glaucoma 101. If your patient is progressing, review the pressure. And if it's too high, lower it. If you see a disc hemorrhage and the pressure is too high, then absolutely, I agree with Professor Sugiyama, immediately intensify treatment. But from here on in, it gets a little more complicated. If you see a disc hemorrhage and the patient is progressing, then consider the state, the rate, the disability, the life expectancy, the benefits and harms of further pressure lowering before you make a decision about what to do with the patient. If you see a disc hemorrhage and the patient is not progressing and the pressure is adequately low, then it is quite okay to observe the patient. But you need to observe them carefully, looking for progression or looking for intraocular pressure anomalies, because they're the two things that are going to have you reconsider your treatment plan. If you observe the patient and you see progression, then we go back to number 4 and we consider all those different aspects before we make a treatment decision. Australia is a lovely place and very pleasant place to visit, but there are some dangers. And for those dangers, we do have warning signs. An optic disc hemorrhage is just the same thing. It's an important warning sign telling you that the optic nerve is under stress. So when you see an optic disc hemorrhage and you need to watch carefully for it, you need to watch carefully, in other words, observe for its treatable consequences. Treat the pressure, treat in respect of progression, but watch the disc hemorrhage and use it as a sign to guide your further observations and determinations. Thank you very much.
Hi everyone, I'm Visney. The debate today for me is uncontrolled IP and JOAG-Y mix. This is my financial disclosure. All right, if you know the JOAG, if you have a patient with under 35 years of age with an active lifestyle, still enjoy their work, positive insight, and taking care of their family, but they got the AOA, JOAG with the MTMT uncontrolled IOP. So the SLT done but unresponsive, what would you do? You think about these guys, active lifestyle, I need to get back daily life ASAP after some procedure has been done. Well, so would you think, after SLT, we need to do with the surgery, but is trabeculectomy a good thing? There are some drawbacks, and they require suturing. They have some degree of conjunctival tissue interruptions. So we thought about mix, but in my country, we have just only with the subconjunctival mix for the SEN. Well, the subconjunctival mix can give us a better choice because the concept is fine. Just put it in and everything, it can provide the flow. And at that time, the flow guide can be provided with the design of itself. Well, after implantation, the eye would be looking quite like this. But when to implant, you have to implant through the cornea and get into the anterior chamber and get into the subconjunctival space. But anyway, do we have other things, other approach that we cannot go into the AC, so we do not interrupt the lens environment in the phakic eyes, just like, in the young people. So I think we've got another approach. Let me show you this implant that's transconjunctivally with the stent. So I start with we don't need to use any side ports. We don't need to use the viscoelastic agents, just made a corneal traction. We put the subconjunctival silicone as usual, and then followed by subconjunctival MMC with the calculated amount. And then when everything just ready for you, and you can see that I didn't do any side port at all. We just put this the stent implant like this, put it through, and you make the corneal traction suture like a counteracting force. And when you can see the stent injector tip inside over there, and then just release it. Release all the injector, and all the thing would be in place. So you can see here, very easy, just only a few minutes to do. And here we go. I can go with other things. So after this, after the several cases, the day one after the stent implant, no leakage. Month 2, month 3, just like this. And because the lesson learned from the ab internal and the transconjunctival, and I do some, the green check, and I think that transconjunctival for me got the better green checks than the ab internal. So I decided to discuss with my patients, 30 years old, female, Thai, strong maternal family history with the 3 topical meds. She got 30 something, but the SLT did not respond. She did not respond well to the SLT. So we decided to go with where the surgery was discussed. Transconjunctival mix was done. The left eye was done first, and you can see the lens in her eye after 4 months, and you can see the subconjunctival bleb over here, and the right eye just like this. You can see the stent inside through the gonioscopy. The eye is still fine. 11 and 10 needling just done at just done once, and still on with the prednisolone assay. So the subconjunctival mix to me reduces intangible costs a lot. It can spend much less OT time. It can have the less operation instrument, and post-op more comfortable. And particularly, they need less post-op visit, less TOSIT, and no need for any suturalized or conjunctival stitch off. So in summary for this, subconjunctival mix deserve the consideration in JOAG patients, and the technique might be opted for something else, just like transconjunctival technique. But anyway, please mandate for the proper case selection. And again, for now, thank you for your kind attention.
Hi, everyone. At the outset, I would like to thank the organizers for the kind invitation. I will be debating on trabeculectomy for uncontrolled IOP in juvenile open-angle glaucoma. No financial disclosures to declare. So I'm starting my debate by presenting a typical case of juvenile open-angle glaucoma that will give characteristic features of the disease that will help in decision-making. Here is a case of 12-year-old girl with a family history of glaucoma with presence with mild ocular plane and known myope, had intraocular pressure in 30s. Gonioscopy showed typical features suggestive of angle dysgenesis with dense iris processes. Right eye had mild disc damage, whereas the left eye had significant disc damage. Characteristically, you have a case of juvenile open-angle glaucoma with a young age, with a family history, high myopia and intraocular pressure, with the characteristic gonio features and moderate disc damage. Juvenile open-angle glaucoma is defined as open-angle glaucoma in younger age, positive family history, autosomal dominant genetic association with myocilin, usually will have a severe disease course with high IOP and myopia. It is usually bilateral, but can start as a unilateral case. The literature suggests that 2/3 of patients with JOAG will have angle dysgenesis, which strongly suggests it is a developmental disease. If the intraocular pressure is kept untreated, it will lead into significant progression and visual impairment. Certain facts one should remember while treating the JOAG. Because of the rarity, little data is available on its clinical characteristics and prognosis. JOAG patients are diagnosed at young age, so will have a long life expectancy. So controlling the disease is very important from the initial stages. Otherwise, it will lead into visual impairment and blindness that will significantly affect the life and their quality of life. So it is very important to control the intraocular pressure. Most of the times, we start with the medical management, but in many cases, surgery becomes essential at some point of time. The challenge we have with the surgery is to preserve the vision by controlling the IOP in a difficult case such as juvenile open-angle glaucoma. The best shot we have is to do a procedure that gives good control of IOP. My counterpart has recommended mix for the JOAG. I would say that she is wrong. Definitely, I will be recommending trabeculectomy. There are a variety of mix available in the last decade or so. Some are canal-based, some are subconjunctival insertion. The only supracaudal space device was withdrawn because of the corneal endothelial damage. It looks like we are still in search of an ideal one. Moreover, they are effective in mild to moderate glaucoma. So all of you will agree, none of them likely to be effective in JOAG with high IOP and angle dysgenesis. I would strongly recommend everyone to look at the current opinion ophthalmology review article, where authors, after taking into account all the available literature, have concluded that mix offers only modest efficacy, and trabecular meshwork and Schlimm's canal-based offers safety, and whereas subconjunctival insertion complications are similar to trab and tube. So definitely they are not offering the safety what people claim. At present point of time, no mix will work for juvenile open-angle glaucoma. Why trabeculectomy? It is time-tested, provides good control of IOP, effective in angle dysgenesis. One can minimize possible complications of trabeculectomy by modifying the technique by adopting fornix-based flaps, applying MMC for large area, and using wound titration with releasable sutures. When you do such a modification, we are likely to get a diffuse posterior bleb, and which will minimize the complications of the trabeculectomy and provides good control of the intraocular pressure, avoids progression. In a rare disease with poor prognosis, first shot is the best shot. Choose a surgery that gives good outcomes such as trabeculectomy. Thank you very much for your patient hearing.
Good afternoon. I am Dr. Nazrul Islam from Bangladesh. I am thankful to 9th World Glaucoma E-Congress for the opportunity. Well, in next 5 minutes, I shall talk in favor of primary trabeculectomy for the management of neovascular glaucoma. I do not have any financial disclosure. If we look to the very recent study on primary TVT, published in Ophthalmology by Stephen G. Getty and his team, treatment outcomes in the primary tube versus trabeculectomy study after 3 years of follow-up. And they found and concluded that trabeculectomy with MMC achieved a lower IOP with use of fewer glaucoma medications compared with tube shunt surgery after 3 years of follow-up. This is a world-famous study. It is conclusive that primary trabeculectomy is the choice of surgery in the neovascular glaucoma. We know 81% of cause of NVG is the CRVO, BRVO, PDR, or the carotid artery occlusion. And you can treat the cause, then of course it can easily be prevented, the angle closer glaucoma to need the surgery. Whenever you need surgery, of course, you need to do comprehensive management. Other than surgery, you have to treat with steroids, cycloplegic agents, IOP lowering agents, pan-retinal photocoagulation, focal laser photocoagulation, anti-VEGF agents like bevacizumab, ranibizumab, along with the surgery. And when this surgery comes, it is the flowchart showing that trabeculectomy with mitomycin C is the primary surgery for the treatment of neovascular glaucoma. Of course, if the trabeculectomy fails, then we can definitely go for the tube shunt surgery. Yuji Takihara and his group showed that if you use the bevacizumab preoperatively and do the trabeculectomy with vitamin C, the outcome becomes much more improved. In another study, Ayman A. Alkabas and et al. Found if you use the pan-retinal photocoagulation and also intravitreal bevacizumab along with trabeculectomy with vitamin C, the results is significantly improved for the control of IOP for longer time. Regarding the trabeculectomy, in the neovascular glaucoma, you have to do a modified trabeculectomy. Like you have to use the higher concentration of mitomycin C, longer exposure time, and of course, you can make a larger flap, a larger block dissection, so that fibrosis will be less and success will be higher. Saito et al. And Takihara et al. Found if you do not use the anti-VEGF agents or the laser, only TRAB with MMC can give you 62% success rate. But if you use the laser and anti-VEGF, the success improves up to 95%. It's very important. Now, if we compare the TRAB and tube, the tube needs more conjunctival dissection, more extensive surgery, more expensive surgery, and not affordable by most patients in the developing country. On the other hand, trabeculectomy is less expensive, more successful in IOP lowering, less vision-threatening complications, as already we have found in the primary TBT study. So, in conclusion, I will say that neovascular glaucoma is a potentially blinding disease, but if you can manage with preoperative anti-VEGF, laser, and modified trabeculectomy, the success becomes more than 95%. So, Dr. Xiulan Zhang, I think she will be now convinced that primary trabeculectomy is the surgical treatment of choice in the neovascular glaucoma, not the tube shunt. Thank you so much.
Good morning or evening, ladies and gentlemen. Thank you, organizer, inviting me here. My name is Xiulan Zhang, came from Zhongshan Ophthalmic Center, Guangzhou, China. Debate is challenging, but I would like to support AMVG should go to primary tube. I don't have financial disclosure. These are AMVG, what we often see in clinical practice. Loss of MVI, severe corneal edema, IOP sharply increase, and pupil dilate. Most of patients have a severe headache, pain in eye, and vision decrease. Nowadays, we already realize that the main reason to cause MVG is retinal ischemia, which the vasoproliferative factors such as VEGF and inflammatory cytokines such as IL-6 were full of visual cavity and anterior chamber, stimulate MV growth in iris and angle to form fibrous membrane and broad chamber angle, and then IOP increase. Since large amount of VEGF and IL-6 accumulated around the filtering area after trabeculectomy, filtering break is easily scarring, so trabeculectomy is not the first choice for MVG. How about MVG eyes? Look at this photograph. MVG eyes has a loss of MV in anterior segment, which is the right side for trabeculectomy. However, after the equator, there is less vessel, which means that if you implant tube here, will be less inflammation and more successful. TBT studies show that tube implantation has more success rate than trabeculectomy in POAG. Our own studies show adjunctive with anti-VEGF, tube implantation for MVG can achieve 80 to 84% of success rate. Another two respective studies showed tube implantation has higher success rate than trabeculectomy in MVG. So tube should be the first option for MVG. Both trabeculectomy and tube implantation has a lot of surgical techniques to guarantee the success rate. I think tube has less disturbance to the anterior chamber if we directly and succeed at one try to penetrate and insert a tube to anterior chamber. Less complication, higher success rate than trabeculectomy. PRP and anti-VEGF treatment create a chance for glaucoma surgery. If IOP drops down, it usually means the eye is either in stage 1 or stage 2. In this stage, trabeculectomy with MNC might be useful. However, after PRP or anti-VEGF treatment, IOP remains still high. It means it is in severe stage, then tube is always cheaper than trabeculectomy. If MEG meets extremely conditions, such as shallow anterior chamber into massive cataract, then we can do like this: anti-VEGF first, cataract extraction, and then tube implantation. So my point is MEG should go to primary tube. Thank you.